Hi, I'm John Cush, Executive Editor of RheumNow.com. It's September the 2nd, 2016, and this is the RheumNow Week in Review. Several interesting items this week. Amgen released its top-line results of a 12-month study comparing denosumab to risedronate in patients who are on steroids. And interestingly, they noted that Prolia or denosumab actually had twice the amount of an increase in BMD compared to risedronate. The FDA has added some new warnings to narcotics and benzodiazepines, two drug classes in sort of hot water these days. It seems to be always in the news. But specifically, they added a box warning, making, I think, adding a greater degree of seriousness to our concerns about the safety of these drugs, and specifically stating that there's a serious risk for sleepiness, respiratory suppression, coma, and even death. A nice review of a population in Ireland looked at what's happened to rheumatoid arthritis in the last decade, from, I believe, 2000 to 2010. And during that 10-year period, they actually noted that hospitalizations and surgeries were cut in half. They also noted that methotrexate prescriptions were increased by almost threefold, and that the number of TNF inhibitor prescriptions rose almost 5,000%. There was a marginal increase in the number of rheumatologists during this time, up to 140. So clearly a change in the way RA is being managed in the modern era. A study from Canada has mirrored a study that was done in the United States that looked at hospitalizations amongst RA patients in gout. And in Canada, they showed more or less the same pattern as that which was seen in rheumatoid arthritis. That being that while RA hospitalizations have been cut in half, the prevalence of gout, for numerous reasons, continues to go up, and as such, the hospitalizations for gout have nearly doubled. This was published just this week and mirrors an early report that appeared in JAMA on the U.S. population. The cost of care in RA overall has not changed from 1998 to 2006, although outpatient care has increased, hospitalizations have decreased. Drug costs are higher, but there are fewer sick days. So overall, the cost of care is about the same, but there's been a major shift in what we're spending our money on. Obviously, spending less on hospitalization and surgery, more on the cost of drugs. Analysis of a population looked at elderly and younger patients who were treated with TNF inhibitors and showed basically the same retention rates, although discontinuation was higher in the elderly for adverse events and for lack of efficacy in a younger population. Earlier this week, Dr. Carol Langford visited my institution, Baylor University Medical Center, and gave grand rounds on ANCA-associated vasculitis and came up with a number of tidbits that we tweeted, including that you can achieve remission with either Cytoxan or Rituxan, and that Rituxan can certainly be used for long-term maintenance with a low risk of relapse. The duration of therapy is not so clear in many of these patients and has to be individualized. She also reviewed the data about the utility of ANCA and showed that ANCA levels really do not correlate with disease activity. And while not saying that they can't be used, for the majority of patients in population management, ANCAs are not predictive. She did discuss the use of Bactrim or trimethoprim sulfamethoxazole, and that it has an important role in isolated upper airway disease, but that it should not be used as a sole therapy for those with organ-specific and serious GPA, such as patients who have glomerulonephritis. That the use of Bactrim should also be encouraged during the induction period, both with Cytoxan and also with rituximab, when patients are starting out their therapy for GPA or for other indications as pneumocystis can occur. It's not so clear that Bactrim is needed for long-term maintenance on either drug, including rituximab. And then lastly, there is an increased risk for venous thromboembolic events in patients with GPA, microscopic polyangiitis, and EGPA or Churg-Strauss. It's not clear whether such patients should receive anticoagulation, and again, it's more like most of those patients will have to be anticoagulated once they have the events. Prophylaxis has not yet been studied in that situation. Some news events. There's a report today that I wrote about the incidence of flares in rheumatoid arthritis. We're familiar with flares. They happen quite commonly. We manage them with analgesics and steroids. But two reports, one from Italy and one from the follow-up of the BEST study, show that there, as a result of having flares, there's a significant amount of damage in patients who have recurrent flares, and that there's a consequence to flares, more than just immediate and short-term pain, that there's functional disease activity and radiographic damage consequences, which led me to state we need to do better than just to give patients Medrol dose packs or intra-articular injections to manage flares, and there needs to be a strategy. Now, obviously the generation of flares is complex and has been multifactorial, weaning off of drugs, inadequate disease control, patient noncompliance, it goes on and on. But again, I think a better strategy is needed for the management of flares in our population. The cost of osteoporosis care has gone up significantly. I think the abstract, which was a review done by the NIH NIAMS division, basically said that 10% of the population has osteoporosis, and that nearly 40% of the population has osteopenia, and that led to a number of, I believe, 55 million Americans who have osteopenia or osteoporosis. That in 2013, $900 million was spent on the care of such conditions, and that for all the patients who have osteoporosis, only 1 in 2 elderly people with osteoporosis are currently receiving a prescription for osteoporosis. That, plus the fact that orthopedists are 3 times more likely to use Forteo and Prolia to manage osteoporosis, led the authors to suggest that there's more education that's needed in this field. The FDA has updated its warnings about denosumab, which actually are similar to that for the bisphosphonates, which were updated in roughly 2014 and 2015, claiming that these drugs may be associated with increased risk of osteonecrosis of the jaw and atypical femoral fractures. But this updated label for denosumab also says that patients should be examined before starting on those drugs. I mean, they should have an oral exam done by you, the prescriber. And if the patients either have dental problems or at risk, they should be sent to a dentist prior to and during therapy. This is a little bit like the label that says that patients with psoriasis and psoriatic arthritis and rheumatoid arthritis on TNF inhibitors actually need to have a skin exam done annually. I don't think that's being done, but that's in the package label and means that you need to refer someone to get that done. The same, again, here applies. You need a strategy to incorporate patients being appropriately examined, or you need to document that you looked inside their mouth and didn't see anything ugly that would indicate ONJ beforehand. And lastly, there's a nice report from Maya Book and the group at Leeds, where they looked at patients with very early scleroderma and Raynaud's. Over 300 patients were screened using nail fold capillaroscopy and showed impressive numbers with essentially a 90% negative predictive value when using that tool to assess patients. So you can find these citations and the links on the website. Tune into Room Now for more news. We'll see you next week.